Good morning, everybody. My talk will consist of two small parts. One is we'll go through the recommendations of the PEDIG study, the PEDIG group. We'll just answer the questions versus going through all the studies. And the second half will be the new advances. It's an interesting concept of how we might be changing the amblyopia management. We'll skip all of these. Why are we talking about amblyopia in this forum? We've known that 2 to 5% of our population, childhood population, is amblyopic. Convert this to our population. We have huge numbers. That's why this part is so important. What treatment modalities do we have right now? Occlusion, penalization, and certain drugs. The other things listed here have been tried, but they are not in use anymore. Before going to any treatment option, it's important that we correct the refractive error. How do we do this? Part of it has been taken over by Dr. Mihir, but the different agents that we use to give the correct refractive error are either cycloplegia or homide or atropine, depending on what we have. What are our general recommendations? If it's an ESO deviation, always give a full plus. Prescribe full cylinders. Do not undercorrect myopes. And if it's a very small refractive error like a 0.5, we can always watch it. These are recommendations already given long back by the American Academy and other stuff. It's all there in the book. But it's good if we follow this. Let's talk about patching or occlusion. It is recommended as early as the 1743, so it's been there for a long time. What are the different combinations that we use? We either patch alone or we patch with penalization, and in certain situations like nystagmus, we still patch. What is the meaning of penalization? What are the different options that we have? We either use atropine in the good eye, the fixing eye, or we combine atropine in the fixing eye with miotics in the other eye if that eye is hypermetropic. Or we sometimes use optical over and under correction. What are the limitations of penalization? It's only some types of refractive errors that can be manipulated by this system, and this can only be used in mild and moderate amblyopia. Of course, this does not exclude the possibility of occlusion amblyopia. So this has a role, but a limited role. Let's go through all the various amblyopia treatment studies. Our gold standard is patch the good eye and make the amblyopic eye work. But there are lots of questions to be answered. One, how much patching? So over the years, we've gone through full-time to part-time to very little patching. So there have been trials which have answered these questions. So if you take moderate amblyopia and compare 2 hours versus 6 hours of patching, at the end of this study they told us that 2 hours of daily patching for moderate amblyopia was enough. What about severe amblyopia? 6 hours or full time? So 6 hours of patching was good enough for severe amblyopia. Next question, do glasses work alone? Yes, in a small population of anisometropic amblyopia. First, give glasses alone. 1/3 of the patients will have a full visual recovery with glasses alone. And for those who don't, then add patching. Begin with 2 hours of daily patching. This may not work for strabismic amblyopia. This is only for anisometropic amblyopia. Anisometropic moderate amblyopia. What about the role of near activity while patching? So clinical trial was done in 3 to 7-year-olds with moderate amblyopia, comparing 2 hours of patching just by itself and 2 hours of patching with near activity. And the results were similar in both groups, which means there is really no need for additional near activity while patching. Can we do anything other than patching? So we've answered the questions of how much you will patch in moderate amblyopes, how much you will patch in significant severe amblyopes, and do you need near activity. All of these are in young children, less than 7 years old. Can we do anything other than patching? Yes. Of course, you can use the Bangerter filters, but I think a very significant different change that has been happening is the use of atropine. So atropine has been studied, where a study was done where they compared atropine versus patching in moderate amblyopes in 3 to 7 year olds, and they found similar results in vision recovery. So the answer is yes, atropine can be used as an alternative to patching in moderate amblyopia. What about severe amblyopia? It may or may not work. How much of atropine will we give? So classically we give 1% atropine once daily. And then there was a study to say, can we extend it to weekly? The answer is yes, but I'm not sure if that works in Indian eyes. So what really happens? So we've either patched or put atropine. What really happens when we come to completion of treatment and now the vision is equal in both eyes? Is there any recurrence of amblyopia? The answer is yes. 24% of successfully treated children slip back into amblyopia, and that is why the need for two things: taper the patching hours before you stop and always monitor after completion of treatment. So once the child is 6 and gone home doesn't mean you don't call them back. What about older children? Does patching work in older children? So studies were done to evaluate the treatment of amblyopia in older children, 7 to less than 18 years of age. And two important things came up. In children 7 to less than 13 years old, 2 to 6 hours of patching, or of course atropine, could improve the visual acuity even if the amblyopia was previously treated. So it's absolutely worth trying if the patient came late to you. And whereas the older ones, the 13 to 18 year olds, there still may be some effect of patching if they were not previously treated. So again, there may be a role where you could patch and see. Can anything else be done? So yes, Levodopa and Carbidopa have been studied for treatment of amblyopia. What is the mechanism? This increases the plasticity of the visual system, thereby making it more responsive to the already existing treatments. It's usually used as an adjunct, mostly not as the first line of treatment, but it definitely adds to speed of recovery, increases the compliance with patching, and sometimes helps improve vision in adult amblyopes. A word of caution: try not to use it in very little children or children who have associated neurological conditions. Now, as a clinician, what does amblyopia mean to me? It means to me reduced visual acuity and impaired binocular vision. Of course, there is a whole list of other dysfunctions of how amblyopia affects everyday life. Amblyopia has classically been attributed to habitual suppression of one eye, and that's why a reduction in the cortical excitatory binocular neurons in V1, which have been thought to be established during the critical period, and they are permanently lost if not treated on time. This is what the whole critical period is all about, and this is what we've studied for many, many years. And that's why we patch, and we've gone through the whole regime of how to patch and what to do. Does this treatment have any limitations? Yes. All of us have had patients who have not reached 6 and 6. We've had times where we've seen no improvement in binocular vision. Traditionally, we've been taught that it does not work in older children more than 18 years of age or adults. Treatment time is usually months to years. And of course, there are psychological and emotional problems. There's been some new thinking here. recent evidence has suggested that the loss of responsiveness of the neurons that we spoke about, there have been some studies in strabismic animals, and it's shown that it is reversible when the interocular suppression is removed. This suggests that there is loss of binocular summation, and it's a result of active suppression. This concept, which was studied in animals, has then been studied in humans between 2005 and 2008, and researchers have actually measured the extent to which the information presented to each eye needs to be different so that binocular combination of the images can happen. This is suppression. So they were trying to understand how much suppression is needed, or how low can the suppression be to achieve binocular vision. These results suggest that it is actually active suppression that renders otherwise structurally intact. Mind you, there is no permanent loss of neurons. It's a structurally intact binocular visual system which actually functions monocularly. So this whole thinking changed, or probably gave a new aspect to, could you treat amblyopia differently? And the newer treatments are now being directed towards directly targeting the suppressive interactions at the visual cortex. So what's the difference? Here, one tackles the loss of binocular function first, and in turn gets improvement in the vision. And how is this done? So researchers have developed a method to arrange viewing conditions under dichoptic presentations where suppression is minimal, and that's why binocular interactions happen. And this has been shown to increase both the binocular vision as well as the monocular vision in the amblyopic eye. How is this done? There are different methods, but basically here how it's done. Either it's done in the office, or it's done on portable devices like this. It's on your phone or your iPad or your tab, or where there are modified games. The most popular game being the Tetris game. I think most of you all would have that on your phone. So this game was modified dichoptically. The adults or the children wear red-green glasses, and there are different images from both eyes. They have to play this game for a few hours a week, and over 4 to 6 weeks there's some changes in the vision and binocular vision. As many as 25 to 26 apps are available. You just download them, and there is a way to, all instructions are given. So what really are these new treatments, and is there any advantage to them? So age is not a barrier to these treatments. Treatment time is reduced. Treatment is more fun for children. There is gain in stereopsis and gain in visual acuity. From the researchers' viewpoint, even adults show some improvement, and visual acuity is, or in most of the studies, has shown some improvement by 0.1 to 0.2 logmar. But these are all initial studies. I think we should wait for more data to come out on this novel treatment before we make any new decisions in our management. And we have, again, the same pediatric, I'll just go through it, 1 minute. The pediatric eye disease investigator group doing their latest study on this treatment, comparing this treatment protocol with the patching, and let's see what we come up with. And if this change does happen, it will change the whole protocol of amblyopia management to come. Thank you.